Hi, everyone. Welcome to this webinar, Family Medicine in Action in Africa. It's great to have all of you around. We're very pleased to have a family physician who works in Tshwane, who's doing some really wonderful work around the drugs pandemic in the Tshwane community. And I think we're going to have a discussion with her about what she does and how she brings out her teaching and learning in family medicine in terms of dealing with this really important challenge in the South African community, if not the global community. So thank you very much to Dr. Urvisha Bhoora. Urvisha, if you can just show your video and we can begin. Thank you to all the participants who've joined us. We're really grateful that you've taken off a Friday afternoon. It's not very easy. And particularly to you, Urvi, really appreciate you giving us this time. The questions that we have is basically tell us more about yourself, Urvisha. I mean, you're a family physician. As I was just telling you now, you're a really young family physician, and it's really thrilling to have such young people doing such great stuff. So go for it. Tell us a little bit about yourself, and I will try and get out of the way while you talk.
Thank you for the introduction. So I'm Urvisha Bhoora. I'm a family physician with the University of Pretoria. I qualified or I graduated 2018, but I started my work with COSAP in the beginning of 2018. So I joined the University of Pretoria, where I immediately started in the community-oriented substance use program. So this program is an initiative between the City of Tshwane and the University of Pretoria, Department of Family Medicine. I believe a few weeks ago you had a discussion with Prof. Yanni about community-oriented primary care. So this basically falls on that. The program is based on the principles of community-oriented primary care. And so basically what happens is that healthcare is taken into the communities and households. We use a harm reduction philosophy in our program, and we also promote demand reduction in substance use. So I don't know if I can just continue on what we actually do in the actual program.
Yeah, tell us what COSAP is about and where you got involved. But to
Sure.
start by telling us about COSAP.
Okay, so community-oriented substance use program. So the whole idea was that we took a look at substance use in the community, and we saw that the traditional concepts of rehab and abstinence-based therapies were just not working. Substance use is really a problem in our communities, and people seem to be going in and out of rehabs as a cycle. There was also a lot of stigma, a lot of poor help-seeking behavior from the part of substance users as well. So basically, we took an evidence-based approach and re-looked at how we manage substance use and harmful substance use. So if you'll notice the terms that I'm using, we started by moving away from terms such as drug addict and addiction. So we've looked at those types of things, and it shows that using more appropriate terms like harmful substance use, substance user as opposed to drug addict, those are the basics of how we started. And we sort of said, well, the traditional approach is not working. So what is working? What should we be doing? And so we looked at a non-judgmental, patient-focused approach. We have 17 outpatient sites all over the city of Tshwane, and that's also something that's different. Traditional rehab programs are more inpatient, where they have outpatient as aftercare. However, the problem with that is that you take the person out of their community, out of their triggers, out of their setting, you take them away for a while, and then you put them back into the same community. So
Absolutely.
this idea is to help people cope with their stresses, cope with their lives within their context. And as family
Mm,
physicians, we always work in a context of a person.
mm,
A
mm.
person is not just a person, it's an individual, a context, and their whole community. So basically we took it out of inpatient and out of facility, but we still have sites all over Tshwane. Tshwane is a very large geographical area. So we have currently 17 sites all over Tshwane, 16 that are active. I'll explain that a bit later. And each team basically has each site has a team with people with varying skills. So you'll have a doctor, myself as a family physician, the family medicine registrars from the University of Pretoria, and very soon the registrars from Sefako Makgato University as well. They work as the doctor for the site, but they're also responsible for sites. They learn about management, they learn how to be leaders. They learn how to basically run a site as well. Then there's a clinical associate. I'm not sure if most people are aware of clinical associates. These are mid-level healthcare workers. Most universities do have them. So these are clinicians, and they basically run them together with the social workers function as the team leaders at the sites. So they are there daily. They work with the clients. The doctors come in about once a week, etc. So it's a team approach: clinical associate, social worker, community health workers, because we are community based. And then very importantly is we have peer educators. So peer educators are people who are either substance users and they still do use, previous substance users, or people who have an extensive knowledge of substance use within the communities that they serve. So peer educators actually assist us in getting to people, in reaching the substance use community. I mean, if you and I just walk into a hotspot of an area where people are using substances, I don't think we'd be welcomed very easily. We can't go in there and start telling people what to do. So the peer educators assist us in reaching people where they are. And so that is a very big part of what we do. We do outreaches. We actually go out into the communities, into the hotspots, and inform them about our services. So the whole idea, like I said earlier, was to change the way we view substance users and how we manage substance use. So we want to create an environment that is inclusive and non-stigmatizing of people who use drugs. And then also for those who are maybe using substances, but have not yet progressed to harmful substance use or have not yet developed substance use disorders, to assist them in preventing that progression. And then in terms of the health side of things, we all know that there are harmful consequences to substance use, harmful health consequences. So we focus on preventing, but as well as treating, managing, facilitating patients' access to health facilities in order for us to manage things like HIV, TB, STIs, even mental health disorders, and any other complications that people may have because of harmful substance use. And then importantly is you can't do anything without community buy-in. The community has to support you. So a lot of our work is about going into the communities, educating them about what we do, educating them about substance use, so that they also can start understanding it and to start supporting those users who do need them. So it's a support, don't punish type of philosophy. So if people can understand them and try and support them, then we are there to help them. At the end of the day, very often people ask us, how do you measure if you're successful? And so this falls back to what is the measure of success? But we look at it as to see how have we improved the quality of life of the substance users, their families, and the communities in which they live. So we don't use abstinence as a marker of success, but we do look at how has the person's life changed? How have they improved their quality of life since joining our program?
Okay, so if I may ask, do you all use any specific measures in that process, like validated tools?
Yes, so there's a few tools that we use. An Assist 3.0, which is a WHO tool, which assesses substance use and its severity, and then we repeat that every 3 months to assess how has the person's score, how is it doing. And then there's also a quality of life tool that is being used at the sites. I can't give you the name of the tool, but it's a validated tool. It's been worked on by the peer educators, and we have an occupational therapist who works with us, and they're busy doing that on clients. So they do a baseline and then they repeat it to see how have things improved in that sense.
Okay. Sorry, I stopped you at the moment. Harm reduction you were talking about.
Yeah. So what I was saying is that our whole philosophy is based on harm reduction, and there's a definition, but basically it makes sense medically. It's practical strategies and ideas that you use so that you can deal or prevent the harmful consequences of drug use. Even drug users are worried about their own health. Everybody is worried about their health, especially now with the COVID pandemic. So even people who do use substances will opt to use a safer alternative. Okay, so if you just have a look, harm reduction as a concept is actually a package of interventions. It's not just a term. So usually centers try and offer all the steps that are shown there. So the comprehensive package would then include needle and syringe programs, opioid substitution therapy, HIV testing and counseling and treatment, etc. So at our sites, we are currently, these are our interventions that we are offering. So you can see opioid substitution therapy and needle exchange programs are part of that, as well as HIV testing and referral to the nearest clinics, and TB screening and referral. We are currently looking at hepatitis B and C testing, and then to start testing for that, and then referring and treating as needed. Another important aspect of our program is psychosocial services that we offer. So the medical treatment is one thing, but in order for people to be able to progress, simple things like people who are homeless and don't have IDs, how do they start with anything? You can't get a job without an ID. So social services are very important in that aspect. So just basic, just getting things in life organized. And then creating individual development plans, they're making goals, small steps, helps people just feel that they've accomplished quite a bit. So our needle and exchange program was quite controversial.
It always is.
In the communities, there was a lot of backlash. We had people, initially when we just started needle exchange programs, our social workers were actually arrested. You won't believe it. Our social workers were arrested because carrying drug paraphernalia is illegal. So it took a lot. We had to do a lot of community engagement, a lot of engagement with law enforcement to make them aware of what we do, how we do it, to then talk to them and tell them, don't break people's needles if you find them with it. If you find them with drugs, it's still illegal, so they have to arrest them, but don't break their stuff, because then they'll just share. So there was a lot of education, and we still have to keep doing it. You always miss people. So that was difficult to get communities to understand the rationale behind giving clean needles and teaching people how to use them. So that was quite difficult, but I think we've come quite a long way from where we started.
Do you all explore medical treatment outpatient wise? In other words, you'll treat in community.
Could you explain that again?
Well, if anybody wants to deal with their drug, management, you'll consider giving them, for example, any of the opioids, or do you look at what do you manage them with?
So currently, we are substance use program in general, so we cover all substances. However, the biggest thing or the biggest problem at the moment, or the highest number of cases we're seeing, is with Nyaupe or Wunga or Unga, whatever the term is in whichever area you're staying. So that, as most people are aware or may not be aware, is a mixture of low-grade heroin mixed with a lot of other things. And then it's either smoked together with cannabis or it is injected. So heroin causes withdrawal. And so that's where the problem lies. A lot of people come to us looking for help because they cannot stop the heroin because of the withdrawals or the severe withdrawals. Even though they're not life-threatening, as with alcohol or benzodiazepine withdrawal, opioid withdrawal is extremely painful and difficult to manage. So we do offer opioid substitution therapy. We currently have more than 700 people in the city of Tshwane on opioid substitution therapy. So we are funded by the city of Tshwane, the program. So they are funding the program. And opioid substitution therapy is not available in state. It is only available as inpatient hospital management for opioid withdrawal for 14 days as a detox. So there is no TTO or no take-home doses that are provided for patients. People leave the hospital, they go straight back to heroin.
I know.
That's why so our program
challenge
focuses,
is this management problem.
It really is a problem. Or the other flip side is that they go into forced withdrawal, then they come out of wherever they are, and then their tolerance is low, and then they go back to using, and then you end up in a situation of accidental overdose. So with opioid substitution therapy, yes, it's a drug, both methadone and Suboxone. They are both drugs. They are strong opioids. However, they are the safer alternative. So we very clearly explain to patients that what they're taking is just a safer substitution therapy. It's not a cure. It's not magic. It's not going to fix everything, but it allows people to regain their life and to regain their dignity. They're able to function. They're able to look for work. They're able to not focus their entire lives or their entire days around hustling for money to get the next heroin fix. So at the moment, we do have that many people on opioid substitution therapy, but because of the cost, if I can just give you a ballpark figure, we've got a 500 ml bottle and you've got a 60 ml bottle. So the 500 ml bottle costs between 800 and 850 Rand. And you would need, say, if you're on a minimum dose of 30 mls, you would need 840 mls a month, which works out to just under 1,500 Rand a month. So for most people, that's not possible at all. And because of this high cost of opioid substitution therapy, there's been a lot of lobbying and a lot of advocacy on our part. We've approached the National EML Council, we've approached SAPRA. At the moment, there's only one pharmaceutical company that produces methadone in the country. It's Equity Pharmaceuticals. So obviously there's no competition. They set the price and our program has to acquire the methadone from private pharmacies. It's not available on state tender. So that is a huge obstacle in treating people. We would be able to treat a lot more people if the price was lower.
Sure. Oh, I think that's great, Will. I think we need to learn lessons from this. You've got lots of experience. Wonderful. Please continue sharing.
So I think what is important for most people, or for most of us, or what I have learned from starting in 2018 to where I am now, if I think about myself as a person and what I knew when I started. So I started just out of registrar time, and then I joined the program. And like I said, what I knew was based on medical school knowledge and very limited exposure to management of substance use or disorders. So I have definitely grown a lot in my journey. And I think the biggest change that I've had to make is in my thinking around substance users. Um, and the biggest shift was that even though we practice harm reduction, I think all of us always have had, a lot of the staff always had the secret hope that people would stop. So you want people to stop because you want them to be better. And that's where you have a conflict, and then you start projecting your expectations. So what we've really learned is to help the people where they are. So it's okay if you're not ready to stop, then we help you with that. If you are ready to stop, we help you with that. If you just want to reduce your level of harm to yourself, we help you with that as well. So that is a big mind change. If you look at it this way, we counsel people for smoking and count overweight diabetics, overweight people, but we still help them. We don't turn people who smoke and come with cancer away. We don't turn away the diabetics whose sugars are not controlled. So in that same light, we look at substance users. You educate them about the harmful consequences of their substance use, and you provide them with the tools to make it safer. But at the end of the day, it is still up to them to choose what path they're on.
So let me ask a question. You do you know anybody personally? I mean, you came into this space. Did you come with some sort of experience already in your context, personal context, of somebody with a drug abuse problem or substance use problem?
Not so personal, but I mean, I think we always know somebody who's had a problem with it, and that person who's always in and out of rehab, that person sort of just this
messed
person
up life.
Yes, and that has changed in that you look at people a bit differently. You sort of previously you may have felt like, oh, this person again, this loser, or this guy who just can't get his life together. And now you sort of see it as, you know what, yes, you have more empathy. I think that is definitely what you gain. And the thing that you understand is that it's a lot more complex than, oh, he should just stop. Because that is what we hear from families. My mother says, oh, why can't I just stop this? And I don't know why. I wish I knew why. I just don't know why, but I can't. So I've learned the complexities of substance use and of users. And if you understand that complexity, then you see why I just can't. And a lot of people have been using substances for 10, 15 years. So that brain chemistry has been altered. Their coping mechanisms are maybe non-existent because they use substances to cope very often. And a lot of our users have been through some previous traumatic event. That is what we know a lot.
Doesn't that also lead you to be dealing with a lot of mental health disorders?
Absolutely.
You must, because there's such a big overlap between the two.
Absolutely. And the most frustrating thing is that the state mental health services are not great. Especially now during lockdown, a lot of the clinics that had closed, it's very difficult. It is extremely difficult. So very often we don't know, it's like a chicken and egg situation. You don't know what came first. Is it the mental health issues that are now leading to substance use, or does this person have a mental health issue because they're using substances? We've diagnosed a lot of not previously diagnosed depression, where we've realized that people are actually using substances to treat their depression.
It's so integrated.
It's so integrated, and the most difficult one, of course, is to work with the substance-induced psychoses, especially now with cannabis being decriminalized. So we work closely with Kalafong Hospital as well, with quite a few of the hospitals that have mental health services. We try and get the users into the programs, etc. But yes, there's absolutely a very big overlap, and it's so difficult to get people or to get mental health users stabilized on both mental health medication and on opioid substitution therapy.
You mentioned the mental health services. I mean, in Johannesburg, as an example, we have quite an extensive psychiatric. I mean, there are about two psychiatrists and a fair number of registrars, and also a reasonable number of psychologists within a circuit of clinics in the community. Do you all have the equivalent, or is it mostly just nurse?
No,
The psychiatric nurses.
no. So we have the larger hospital, Vescopi's Hospital, which serves the Greater
Yeah,
Pretoria area.
excluding the hospitals
And then we
in
have
in the primary
district
care.
psychiatrists. Yes, we have district psychiatrists, which visit certain mental. So not all primary health care clinics have mental health facilities, and I don't know if that
Sure.
situation is there in Johannesburg as well. But in the
No,
city of
no, there's
Tshwane,
only a smattering of them, like
yeah,
about a dozen.
yeah. So you have local authority clinics, and then you have the larger provincial
Province.
clinics.
Yeah,
So it's at the larger clinics where you would find mental health services.
that's
And then
right.
it's at these clinics you would find the visiting psychiatrist and the
Yes,
psychologist as well.
right,
So often it's quite a distance for people to travel to get
right,
to their nearest mental health facility.
right.
And so those are the challenges that people are facing.
So are you working with them together in a collaborative fashion in this whole program?
So two of our sites, so remember I mentioned we have 17 sites. So
Yes.
one is at a hospital. We are based in a container clinic outside the hospital, just
Which
on the
hospital?
hospital, Mamelodi Regional Hospital.
Right,
And then we were at Tshwane District Hospital.
right.
But because Tshwane is a COVID dedicated hospital, the hospital was shut down, other services were shut down.
Yes.
So our site had to move from there. So that site integrated with one of our inner city sites. Then we have a site at Laudium Community Health Center. There they have mental health services. So we have a good relationship with the mental health care system there.
Right.
So there's a lot of referrals up and down. And then yes, there is a community health center as well, district clinic. So we have a site in the clinic and we work closely with the sisters there as well.
So in terms of this program, and I'm just talking generically, you perhaps can just sort of give us a general view. So effectively, with these two sort of hospital sites, have you gone into the clinics and sort of tried to link that, or with the psychiatrist, put the COSUP into the mental health, or is it creating a separate little unit dealing only with the drug abuse but linked closely with the mental health services? How does that
Yes.
work?
So the idea is to integrate services ultimately.
Yeah,
It hasn't been as easy to do that.
right.
When we started, the idea was always to try and get into clinics, but there were always issues like space
Right.
and stigma. People don't want substance users in their clinics.
Seriously? Oh,
Things get
wow.
missing, anything goes missing, and it's your
Ah,
clients. And I'll be fair, there were instances where our patients did steal taps. so
wow.
so I won't
Anything
say it
happens
doesn't
with
happen. I won't say it didn't
true.
happen.
It is a challenge.
So it happens. So we've had those issues, but in the facilities where we are, it's more of a referral based system. So if we identify someone with mental health issues, we will refer to mental health services. Or if they identify someone who has substance use problems, they will refer to us. So
Yeah.
it's not really integrated together. We work as, it's sort of like a different department within the clinic.
Yeah. Yeah. Okay. So I think, Lindsay, we've got a question. Do you mind
Mhm.
asking the question, Lindsay? Lindsay, I've given you permission to talk. You can just unmute and go ahead. Just press your space button. It's actually as simple as that.
Hi, can you hear me now?
Yes, Lindsay, very well.
I've got lots of questions, but I'm going to limit myself.
Great.
No. Keep the conversation. I think
boring.
that it's okay if you've got lots of questions. But go ahead, Lindsay.
It's fantastic work. So who is funding the program? Because some of the medicines you're using are actually not even on state tender.
Exactly.
So who pays the salaries? Who's paying for services?
Who's
The
paying for
city
all
of
these
Tshwane.
lovely people in that space, and how's it
The
worked
city of
out?
Tshwane.
City of Tshwane.
We are funded by the city of Tshwane, yeah.
Now you've mentioned the doctor. Are all the doctors in the employ of Gauteng Health, I assume, or are some
So
of them
city of
coming from
Tshwane,
city?
so city of Tshwane is different to Gauteng Health. So we have
Yes.
registrars who are obviously part of the university and paid by the Department of Health, who
Gauteng.
rotate.
Right.
Myself, I'm the only doctor employed by the actual program. The other doctors are employed by Gauteng Health, and then they
Right.
sort of get seconded
in.
to CASA, because they are not there full time. So
Right.
they provide only a service part time,
And what sort of time do they provide to it?
about once a week per site.
All right. And
So
then
we
you,
have a few doctors. We have, I would say, one doctor covers about 3 or 4 sites.
all right. Then you mentioned community health workers, which I assume are the current WOBOT team. And
We
kind
have
of
our own
own.
employed. Yes, we have our own employed by the program.
All
So
right.
these work specifically with us, but there's always linkage with the existing community members as well. We've actually done training with the community health
Broader
workers
bunch.
from the
Very
WOBA
good.
teams as well, yes.
Yeah,
But the
sounds good.
community health workers in the program are employed by us.
Good. And then the peer educators, are they getting a stipend or
No, they get a
are,
salary. They're
or they
employed
get a
by us as
salary?
well. Yeah.
Okay. And the psychologist, you mentioned student
So
psychologist?
so the
Student,
psychology interns, so we have a lot of partnerships. So the psychology interns is a partnership that we have with FPD.
Okay.
So the psychology interns are from FPD.
Well, we'd love to get. I think Lindsay, you can. We'd love to get your the agreement with City. I think that I'd certainly like to take it to the city of Johannesburg and propose a similar program in Johannesburg. So please share any of the documents. I've sent you an email, but we can put it out there on the web page for anybody to look at. Lindsay, any other questions? And I think that we'll come to. I think there's plenty of time. So if you've got questions, please feel free. I mean, you've got the ideal opportunity with Urvi being available. So pick a brain.
So
And any other questions from anyone else? Yeah.
Have you noticed any change in your client profile after the legalization of marijuana? Have you noticed an impact of that yet, or are you expecting something to come?
So I think they may experience it more in the hospital setting. I mean, the biggest thing that we would see is acute psychosis. We don't really see it in our sites, not specifically with marijuana. But I know the hospitals have seen an increase in the number of acute psychoses admissions. So personally, I don't, I think there is a risk, but I think with the decriminalization of marijuana, there needs to be more work done on regulations and education. I know European countries have restrictions on strength of marijuana, on things like that. They've regulated it quite well. I mean, to having an age limit, the type that can be used, etc. So no, we haven't seen it at our outpatient sites, but I know they have seen it in a few of the hospital settings where they do 72-hour observations for psychosis.
You mentioned 17 sites. Are all of them in the city of Johannesburg, or are there any in the province? Tshwane, sorry.
All of them in the city of Tshwane. So
all
if
of
I
them
can,
in the link.
A city of Tshwane is very large geographically.
When I say city of Tshwane, I mean the local government sites. You mentioned CHCs, so it looks like it's not just
maybe
their facility.
Maybe I can explain. So our sites are not only at health facilities. Some of them are at churches. Some of them are in other NGOs. So for example, I'll tell you, in Mamelodi, we have 3 sites. The one is at the hospital. The one is at on a church premises, a private church where
Right.
we rent to them. And the other one is an old Wabot station that we've sort of renovated. So it varies. The sites are not all at health facilities. They range from NGOs, NPOs. Some of them are just on a space that we found and we used it. So that's how it works. The sites are not all the same.
And do you work?
But I mean, we range from the inner city.
Yeah.
We go all the way up north to Soshanguve, Garankuwa, Mabopane, and all the way south, all the way down to the border of Johannesburg where Olivenhout Bosch is.
Yes.
And then Mamelodi on the east, and then Pretoria west as well to the border of northwest where Daspoort, etc. is. So we cover most of Tshwane.
Yeah.
We are looking to get into region 5 and 7 as well as region 2, Hammanskraal. So those are quite far, Hammanskraal, Bronkhorstspruit, and Cullinan area.
So are the sub-district managers quite leading the way forward, or are you all kind of having to push the cart, push the barrow all the time?
Well, yeah, we do a lot of the pushing.
Is it? Okay.
Yeah.
Okay.
People don't.
So I think that's quite a challenge. Go ahead. Sorry.
So, like I said previously, substance users are not popular people. So very often we have to sort of motivate people to want to work with. Everybody will acknowledge that it's a problem. Everybody will acknowledge that my community has a problem. But our approach is not traditional and not. We don't promise that, okay, we are going to get everyone to stop. So it takes a lot of time for people to start warming up to the concepts of harm reduction and substitution therapy and needle exchange and things like that.
Yeah. So have you engaged with counselors and any other community? Just share your experiences with that. And Lindsay, if you want to jump in, just let me know.
So we have to engage with the community at all levels, especially in communities that are volatile, communities that are prone to having violent reactions or bad reactions. We have to engage with ward counselors. Sorry, it's raining. Yeah, I hope you can hear me.
That's fine. Don't worry. It's okay.
So we have to engage with them. We try to join community dialogues as far as possible. We have people who are appointed to do. That's why the community health workers are so important, because they are from the community in which they work, so they know. Partake in community dialogues, invite ward counselors. Working with the police is so important. Working with the NGOs and all the organizations within the communities are also important. So working with the local RDACs and LDACs, the local drug action committees and the regional drug action committees as well.
When you say these,
yes, we've had lots of conversations.
So this committee you mentioned just now, action committees, what are those?
So South Africa, or each province, works according to the National Drug Master Plan. So the National Drug Master Plan is what guides all management of substance use. So there's a new one out that was 2019 to 2023. And all drug, in the National Drug Master Plan, they always talk about regional and local drug action committees. So these are formed by each community and committee. And so they are basically tasked with managing substance use within their communities. So we have to work with them in order to make it work. So they haven't traditionally been very well organized or very well functioning. So part of what we do is also to assist them to get organized, to get structured, and then to move forward.
Good. Any other questions, Lindsay? Any thoughts? You had lots of questions. I'm sure you can add some. And anybody in the, attendees, please feel free to add comments or questions. Lindsay, anything you'd like to add? Yeah. Go ahead.
Could I have a bit more on skills development? I mean, I'm not sure what that means. That's quite broad. Yeah.
Okay, sure. So most most of our guys don't have a matric, or those that do have a matric have not ever worked before.
Are you referring to community health workers, peer educators,
Substance
or
users.
the users themselves?
The
right?
users are clients.
Okay.
So what happens is that now they've made a decision to change their lifestyles. They get onto opioid substitution therapy, but now what? So skills development assists them. So not everybody is able to complete school. So those that are, we assist them to get into basic education, basic literacy programs. They can only do that if they're on opioid substitution or some sort of treatment, so that they're not withdrawing. You cannot send somebody who's in acute withdrawal to now sit and listen for a whole day about skills. So once we get them stabilized on treatment, we're able to send them to our partnering organizations. So we work with organizations like POPs, Pop-Up, and other skills development programs within the communities. So they help them with, for example, basic literacy, or they can do basic courses like plumbing, basic computer skills. There's just a whole lot of life skills that they get to do, and that they do in the hope of gaining future employment. So our social workers would then work with the facilities, and they refer them based on their level of literacy, their level of previous education, and what their interests are. So plumbing courses, basic electrical, technical things, painting, handy workmanship, stuff like that. So they send them to these training centers so that they can complete a course.
Is that arranged through the city, or is the program through you? You've organized that.
Yeah, but these partners are city partners.
Right.
So these are already existing organizations that are I wouldn't say necessarily funded, but they're
available.
Yes.
Yeah.
And they're known to the city. So we've utilized the existing structures that are there, and then partnered with them to send people to these organizations and facilities.
And I mean, all you need is the coordination, around a focus like you're doing, and there's all sorts of willing bodies out there to help this. Because in Shewelo, when we did a community prioritizing exercise and asked them what impact on your health, the number one thing was, well, money. We don't have enough money. We're poor. But the second thing, which really surprised everyone, certainly me, was drugs. That's what they said affects their health. That's the community speaking. And it was
the other thing that often happens is we've had guys who've then gotten work, and then they got money, and then they didn't know how to cope with all that money. So
what do you mean by that? Do you mean they weren't in
money
that process?
Was a trigger. Money was a
trigger.
I
mean, didn't you find a way to build their skills up so that by the time they got there,
so they do
already on path?
They work, but you must realize most of these guys have been living from hand to mouth for years. This is all they know. This is all they've been doing. Now they have all this money, and
does it trigger?
Does
it trigger the relapse?
It does trigger. Wow. It triggers it slowly though. So it triggers it like, okay, I'll just use a little bit and then I'm going to stop. And then it progresses. So a lot of our social workers also have to work on that. How to manage your money. People have actually come to our guys and said, please keep my money because I'm going to spend it. And we were not in the wrong way. We can't do that. So please keep my money, because I can't have all this money. So we had to think of ways to, okay, you have a bank account, put in your bank account, or do something. We had to help them make actual life plans.
Decisions.
Life plans so that they don't just spend it all.
Wow, that sounds amazing, actually, that you are helping them so comprehensively.
Yeah.
What about the social context? I mean, at the end of the day, I'm just curious about the triggers. Like you said, this program is very premised on we're not taking them in an artificial setting of a hospital and then plonking them back. But you're doing that, you're doing it in situ. They're there, they're living in their spaces. But you kind of have a situation where, yes, you're helping them, but how do you work against the grain of their context, their friends and their habits, and how do you work through that? I mean, how do you engage with that? Because that's really tough.
So it's very difficult. And I can honestly say, as a doctor, I'm glad I don't have to deal with that alone.
Directly.
That is a lot of what the social workers do. So a lot of
What about the
individual
community health
therapy.
workers and the peer educators? Do you think that
Yes.
you seem to talk of social workers quite substantially?
So what the peer educators are also great at doing is hosting what we call CAGs, so community advisory groups. Now this is before COVID, before we were allowed to have, before when we did have groups, and they would have groups with the users run by the peers. I mean, social workers would also have groups, but I think some things a substance user won't say to social workers, they would only be comfortable saying to their peers.
Yeah.
And so they deal with a lot of those issues. It's complex.
I know.
And we have people relapse. We do have people relapsing. I won't say, oh, methadone has saved us completely, but it has definitely assisted us in managing those problems. But these are realities. People walk around a corner that they've been walking for 10 years and they know that the dealer is on that corner. Now they have to change the road they walk, that they've been walking every day, just so that they don't go past that way. Simple things like that. Substance users have also been alienated from everyone, and the only community they have are their users, their community of users. Now they're not using anymore, so where do they belong? A lot of them have been isolated from their families. So family reintegration, family reunification is also something that we try to work on, but that's not always so easy.
Actually, yeah, no, that would be quite important. There's such a lot of trust broken down in a family. I mean, it's really hard to build up again. So do you spend quite a bit of time? Is that what the social workers doing?
They do. So they do a lot of group work. They do a lot of individual therapy. They do family counseling as well. But we've also find sometimes families end up being to the detriment of the patient, and they're better off without them. We've seen families now put pressure on people. Oh, you're on medication now. Time to get a job and support us. So there's a lot of, it's complicated. Well, that is the one word I can say. It's complicated, and it's not just you should stop. So it's very complex. Families, they do assist. I mean, we find that people who live at home do better than those who are homeless because they have some sort of support structure as well. Just a roof over their heads. That makes a huge difference on how they do. What I did want to mention, which I'm particularly
I think you have the undergraduate, postgraduate program.
Yes.
Yeah.
So,
but before you go there, I want to just quickly ask one question. Yeah. Have you published anything around this? Have you got documentation? Because I think that people would like to know more, I'm sure, about this program. So if you have them, you'll email it to me.
I will. I can't rattle off the
Yeah, don't worry. You'll just send it to me and I'll put it on the website. Whatever you've got written up, then at least people have access to that. It'd be great to see more detail. So feel free to talk about the education program in the university, how you're using this as a platform to educate students, which is really good.
So, I mean, there's always been limited exposure and knowledge about managing substance use. I mean, I've said that before, from medical students all the way up, nursing, everyone. So at the moment, I can say there's more than 1,000 students at the University of Pretoria that get exposed to COSAP annually. And this is not just medical students, but occupational therapy and physiotherapy students as well. The occupational therapy and physiotherapy students do their practicals. Physiotherapy, not so much, but definitely the occupational therapists, because they do it mental health, substance use. They come to the sites, they plan activities, and the clients love it. They love it when the students come. And the students are very good. They're very engaging. One of the sites in Mamelodi, Lusaka, the students actually joined in on our Jerusalem challenge, and they danced with the clients. So that was really good. So they really do become involved. But I think since we've implemented COSAP, the medical students are definitely better exposed, not just to substance users, but the context in which they are. So they go to the actual sites, they see the clients in their communities, and they can see the realities of what the substance users are facing. At first year level, first year medical students, they go to CASAP sites, they observe what is done. If the users give them permission, then they may speak to the users, they interact with the staff, and they get an idea of what is done. Then fourth years, again, they go interact and they see. And then in fifth year, medical students have a week of HIV and drugs. And here they go again, and they're refreshed on CASAP. They interact with the staff as well as the clients, just to better understand. And I think it's important, because then the students are exposed to the health consequences of substance use, but then they understand community, they understand context, they understand where the person is living. And we are aiming to break pre-existing notions and stigmas, so that when these doctors or these future doctors graduate, they have a better understanding of the substance user and of the communities. So they will learn how to treat, and I don't mean treat just medically, but how to treat a person better. They will definitely, it affords us the opportunity to break any pre-existing stigmas, notions, preconceived ideas, and open students' minds to this new way of looking at substance users. And then postgraduate level, we have family medicine registrars from the University of Pretoria, and soon at Sekpako Makhato as well, who rotate at the different sites during the community-oriented primary care rotation. And so the registrars form part of the actual team. And here they get exposed to not just the patients, but they actually understand how we do it. I just wanted to show you some evidence that I have for 100, and this is how, I don't want to say how we sell it, but it is something that is important to note for anyone who thinks that why is harm reduction important? And obviously for students, we have to show them the evidence post-grad, and for us as well, we have to show why is this working? You can't just tell me this. So, I mean, there was a study conducted here in South Africa between the 3 cities, and just to detect the hepatitis prevalence in our cities. And if you can see there, in the prevalence of hepatitis C range from 29 to 73%. And in Pretoria alone, up to 29% of people who inject drugs are found to be co-infected with HIV and hepatitis C. And if you all know, hepatitis C is not something we can treat easily. Hepatitis HIV, yes. Hepatitis B, yes. It's ARVs, but hepatitis C needs to be treated with direct acting antivirals, and these are not available easily in the country. Even at tertiary level, the hospital has to apply for Section 21 approval, and then it is then imported from India. So treating hepatitis C is difficult. It has to be at complicated stage. So this is some of the things we're teaching the registrars, the students. These are the concepts that we need to teach them medically. Why are we doing what we're doing? This is what we're trying to prevent. And even for needle exchange. I mean, if you look at it, the risk is as high as 90% for contracting hepatitis C if you are an injecting drug users. That's because of needle sharing. So to prevent that, it's so important. So the registrars actually learn a lot also about use of methadone and Suboxone. So these are the 2 drugs that we use as opioid substitution therapy. And I mean, this is something you don't learn about in medical school. You know about it by name, maybe, if you went through that section well, but it's not something we've ever used. I mean, I had to really read and learn, and I mean, it's only now, I would say, over the last year or 2 that I'm comfortable with it. It's a Schedule 6 drug. It's dangerous. It can overdose. So people are very nervous, even in hospital settings. We've got people phoning us, asking us, how do we use this? And people struggle with it because it's unknown, because it's not commonly used. So we teach the registrars how to use methadone, what it is. I talked about the price of it as well. So how we do it. And then also so we teach them how to initiate, how to titrate the dosage, how to go up, how to go down. But most of the medication at the site that we do is done daily observed treatment. So like DOTS, like for TB. So the clients come to the sites every day for initiation phase to get the medication, and then the dose is titrated according to response. As the client develops the relationship, as they do better, they move to maintenance phase, and then we can start giving them take-home doses in case they're working. And of course, over the weekends, we do give them medication as well. Yeah, the other drug we use is Suboxone, but it's more expensive. And we don't use it as much as methadone, because methadone is the gold standard.
Yeah, tell us a bit about the COVID challenge. I think you can then finish your presentation and we can take questions. I think Lindsay's got a question, and maybe we can see if anyone else has. Yeah, go ahead.
So I think all of us have had challenges in COVID.
Of course.
I mean, I don't know any single person who's not had a challenge. In the globe, exactly. So our challenges were twofold. We had patient challenges, and then we had actual site and staff challenges. So at patient level, people struggled to access their substances, yes, but more to access the hustle. The guys couldn't beg at the side of the roads. The guys couldn't sell things on the side of the roads. The car guards were nowhere to be found. I mean, the country was shut down. There was nobody. So how do
what
people...
impact did that have?
So exactly. So people struggled, and we were worried that everybody's going to go into forced withdrawal, and then they're going to get drugs, and then everyone's going to overdose, because that's what happens with forced withdrawal. They use again, and then... So we were really stressed about that. And then, of course, we had the homeless population. In Tshwane, everybody was placed in shelters all over Tshwane. There's an article about that I can definitely share with you.
Please do, please do.
And that unmasked this heroin or nyalpe problem unbelievably. People were placed in shelters, and then people started withdrawing. Hundreds of people started withdrawing. So now what?
So you got called up by all the shelters?
So the district, it was either that or you take hundreds of people to the hospital to manage withdrawal, but that doesn't make sense in COVID, and we've been doing this. So we had to scramble, mobilize our teams, as you can't believe, and start working in shelters. So we started providing health services in shelters, and started providing methadone for people withdrawing in shelters. And I've already mentioned the cost of methadone, and it still wasn't available to us from the state, really. We already had 552 people on methadone and 60 people on Suboxone by the end of March. Now we've got hundreds of people in the shelters, and we also had people coming to the site saying, I can't get my drugs, I need help, I'm withdrawing. So it was a huge conundrum. I mean, okay, so at the site, what we did is the basics of hand sanitizing, face masks, screening, those who
Sorry, I think, okay. So you missed, your sound disappeared for a second.
Oh,
go ahead.
Am I back?
Yeah, you're back.
Okay, so at the sites, we tried to reduce movement. People who were on methadone were given larger decants of methadone to take home so that they didn't need to move around as much. And then we had to talk about harm reduction principles with a COVID prevention strategy. Don't share your joints, don't share your cigarettes. Try to wash your hands before you prepare your drugs, clean your tables, your surfaces, basic things like that, things that we never thought of doing And then a lot of people were like, how do I wash my hands? I don't have water in where I stay. So many challenges. And then our site in TDH closed because TDH was now a COVID dedicated
The
hospital.
Tshwane
So we had to
district,
move people to the inner city. So we lost a few clients there. But what did happen is that, so if I can just put it this way, we had more than 550 opioid users in the shelters alone.
Oh, wow.
Yeah.
So
And
that doubled your program, didn't it?
so, I mean, it did. But in the shelters, our idea was to just treat withdrawal. Remember, we're not forcing anyone into the program. So
Yeah.
a lot of these guys wanted to still continue using the substances.
Wow.
So when we discussed needle exchange in the shelters, that was a big no-no. So we said, okay, we'll give methadone in the shelters to those who are withdrawing. So we managed to get methadone from the district pharmacy and the district health system.
Wow.
But if you look at the quantity, so we got 331 bottles of 60 mils, and that was enough to treat 662 people only for 2 days on a low dose of 15 mils, which is an initiation dose. So that basically gave us 2.5 days of treatment. And then the rest of that was from the project and from the...
I see you mentioned your tramadol being used.
So then second line treatment on the EDL is tramadol, 200 milligrams BD. And the district offered us tramadol to use in the sites and in the shelters as part of the COVID response. So we started using tramadol. And I'm doing a study at the site in Mamelodi where we use tramadol for our clients and to see the effect of it or to see the adequacy of it. And so far, what we're finding is that it's not as adequate as methadone. So unfortunately, so what was made available to us was short-acting 50 milligram capsules. And the dosage is 200 milligrams twice a day, according to the ML, which makes it 4 tablets twice a day. But now these are short-acting tablets. So the biggest complaint that we received is that the tablets work mildly for about 2 hours.
Wow.
And then one of the biggest side effects is insomnia with the tramadol. So people were still having to top up on top of the tramadol. So interestingly enough, there's not much literature on tramadol there's nothing in South Africa. And a lot of the literature on tramadol is for countries like India, Pakistan, Bangladesh, where they have a natural opium. So they use poppy husk, things like that, the naturally growing opium. And that is a milder opioid. So the tramadol seems to work for opioid users of the natural type. So a lot of the literature is actually based on that type of opium, not street heroin. So this article here in the Journal of Addictive Diseases compared tramadol 600 milligrams a day, so that's 300 twice a day, to 30 mils of methadone, which is the effective dose. But we're not seeing that same effect. And the problem is the side effects of tramadol. Before they can get to that 600 milligrams a day, the side effects are causing people to stop.
Okay.
And it's not recommended as maintenance therapy at all by the WHO, only for withdrawal. So in the shelters, we started using tramadol. At one of the shelters, we were told, no, we don't want your tramadol. Don't come back unless you have methadone. So it doesn't work.
Well,
what we're seeing is it doesn't work as well.
Yeah,
but it helps a little.
Well, we certainly need to, come together about how we press government about the issue. I think it's we have to ask the question. I think thanks very much, Urvi, for the share. I think you've got some references. You'll share the slides and the documents if you have them. Sorry, Lindsay, you had a question. Go for it. And Fred, I'd really like to see some. I think we've got some people from outside of South Africa. I'd be very interested in what their problem is. The drug problem, is it big or not in Africa? I think that'd be
So
very interesting.
Kenya has a really, really good and really big methadone program as well.
Okay.
So I know Kenya, Mauritius, I think, as well.
Okay. Very interesting.
And actually, on a personal note, when I was it Mauritius or Seychelles? They actually, in their bathrooms, they have places to dispose of needles,
Oh, wow. Okay.
which is interesting. So in terms of African countries, I know Kenya definitely has a big methadone program.
Well, very interesting food for thought. Thank you very much. Lindsay, do you have something to ask? You had a question earlier. Anything?
No, thanks, Rio. So you're focusing very much on the hard drugs that are much more problematic, and I'm sure there is some coexistence with alcohol abuse. But at some point in the future, is alcohol going to be one of the substances that you're going to be including, or not?
Yeah.
Because I think in terms of numbers, it's more of a problem, but maybe more difficult to socially
To change.
acceptable. So yeah.
So that's just it. So alcohol is actually the biggest problem in the country, and we saw that with lockdown. Hospital admissions decreased, emergency room. Us as a country have a huge problem with alcohol. So alcohol is one of those that's very difficult to treat. In an outpatient program, we don't have many. Like I said, most of our clients who come to us are heroin users or Nyaope users. The alcohol problem is more, it seems that people tend to go to rehab for alcohol problems. And I think it's also something that we need to learn about as a program. We started off completely fresh, not knowing much, but I think as a program, that is something we need to look at and look at how we can improve our approach to harmful alcohol use as well.
I think there's a whole range of, substance abuse out there that we need to think of and how to prioritize. If I'm not mistaken, this was quite focused immediately on the sort of Nyaope because it's community profile. And I think also the problem is that there's been such a poor response, both state and broadly, by civil society. The response has not been very impressive, and it's just such a destruction in the community. So I suppose, like we said, Lindsay, it's socially acceptable, perhaps. There are existing responses that this program is the way it is. So any comments from Fred? I've asked Fred to speak. Fred, if you don't mind sharing where you're from, but I'm particularly keen on where you're from and what you see as the sort of drug issues in the country where you're from, Fred. You just unmute yourself. You can just press the space bar. Good, there it is.
Oh, thank you.
Yes, Fred. I hope you don't mind me asking you to do this.
No, it's quite fine.
Good, thank you.
No, I think, of course, I've not dealt with drugs that much.
Where are you from, Fred? Just remind us. I know I've got you on my list, but Uganda. Right. So you say there's not much of an issue in that space, part of the world.
For me, as somebody as public health person, yes, there is an issue, but it is not that much. We are not seeing that many clinics. Of course, they are there in some of these, in some of the suburbs around the town. But it's really quite interesting listening to her and seeing the way the whole family medicine there is integrated with community work, and I really appreciate it, and I'm just thinking, yes, that's the way to go. It's a question of how do you get the political powers appreciate that you need a physician, yes, a family physician or a doctor, whether it's a family physician or a general practitioner, but that you can't run in the communities, and you need to have some of these people helping you out, doing some of these, and actually making your life much, much easier, but making sure that you reach those who need services. Maybe they may not be able to always come forward, because I know this. We've been doing some studies on drugs. People use drugs in Kampala, but there are people who don't want to be people who what do they call them? There are people, they are somewhere, but they don't want to be known. We all don't know where they are, but they are there. And sometimes when you have to do anything with them, you have to use you have to identify some who are a little easier to deal with. Then they can lead you to the others, even introduce you. Otherwise, you really can't just go on to these areas and say, look, I want to help you. You can become a casualty yourself.
No, true. Fred, to be honest, though, I mean, Urvi Dr. Bhoora has just said, that whilst it was supported by the city of Johannesburg as local government goes, there is in no ways broad wholesale support coming from government. Government is not saying, please do this. No. In fact, I think if you listen to the conversation from Professor Hugo 2 weeks ago, he's probably doing it despite government.
I missed that one.
In other words, I'm saying that don't wait for government to tell you to do something. You need to find a little way to do it yourself. And I hope that, if anything, you can see this example and try to do something yourself. So I think it's very important to understand, I think, as colleagues across Africa, that there is no ways that government is getting us right. That's why we're doing this. We're putting this family medicine in action to say to them, you don't appreciate what we're doing. Look at this great example of somebody doing something, not because government is saying do it, but because we think it's right. And we push and push and push. And then here comes a small project that gets some little support. And it's doing marvelous stuff. And I think that's what all of us as family physicians need to do, is to push and push in our little spaces, take inspiration from some of the work being done, and to do it. So I think, Urvi, do you think I mean, what do you think about what we've just said now?
No, I agree. It just takes, I mean, this is definitely not national. I mean, even if you look at, there was a presidential statement with regards to with regards to what to do with substance use withdrawal in the shelters. And nowhere in there do they mention methadone or anything, but we did what we know.
Yeah.
And it just takes one person to, with us, we are lucky in that the city of Tshwane, even within the city of Tshwane, we had opposition, but we had people who believed in the program, who pushed for it. Initially, when we started, there was no opioid substitution therapy. There was only psychosocial interventions. And then we learned about it. And then they approved us to reallocate our budget to substitution therapy. We started with 50 patients. And now we're more than 700.
And I think what Fred said is really, in closing, I would say, Fred, here's an opportunity. And what you said was exactly what we need to do. As family physicians, go out there and talk to people, knock on the doors, build a network of people who will do it, but do it by action, not talk. And I think that's really, amazing stuff you've done. Urvi, I want to close in the next minute, and just thank you very much for the time you spent with us and sharing this project. I think Dr. Petkova said wonderful project. I certainly would like to have you share the stuff. I would like to call you to see if I can knock a door at the city of Johannesburg and say, you know what, do you know what's going on in Tshwane? Let's get them to hear it. Yes, right next door, they're doing this. You guys are going to look stupid. Come, let's do this. We gotta just be politicians. And I think as family physicians, we skilled at managing people. So Fred and all of you on the call, that's the way to get family medicine in action, is take these wonderful examples that have been shared and knock on doors, make sure we get our voice heard. So I want to say once again, thank you to all of you who've joined us. And thank you to Dr. Bhoora, who is single-handedly, I think, driving this project in Tshwane. Well, lots of teamwork, but I'm saying one person can make a difference. And I think she's making a really big difference. So thank you, Dr. Bhoora.
Thank you for inviting me.
Wonderful to have you. Take care, everyone. Enjoy your weekend. Be safe. See you next week.
Bye.
Bye-bye.